Okay, so I'm a little bit early. I've just decided to set things up. I don't know if people can hear me or not. Anyone can send me a little wave just to let me know that it's working. That'd be great. Now, look, the topic tonight is all about implants. And breast implants specifically have been in the media a lot lately, especially in relation to recent publications out of the Therapeutic Goods Administration, the TGA here in Australia, and other things internationally as well, all in relation to ALCL, which is quite a rare form of cancer that can occur in relation to breast implants. Trish from Plastic Surgery Hub has asked me to talk about breast implants, what we know about them at this point in time. I've received a lot of questions in the lead up to this, which we'll start with, but by all means, there is the ability to just type questions in on the system in front of you. So I'll keep my eye on that. I'm going to talk until probably around about 8:30. So if you've got the time to hang around, that's great. Feel free to get involved. So the first question that we've received essentially is pretty broad, and it's, are all textured implants bad? And the direct answer for that is no. The current position with what we know as plastic surgeons, which is all, or what I understand, is all based on evidence that's been published from Anand Diva's group in Sydney. He is a professor of plastic surgery down there, and he's someone that attends a lot of our conferences and is internationally recognised as being quite a thought leader in this field. His research to date has indicated that texturing of implant surfaces is associated with ALCL. He's managed to, with his team, determine which textured surfaces have got a higher risk compared to others. And so the immediate answer to are all textured implants bad is no. We know that macro textured implants have got a higher risk of developing ALCL than other implants on the market. The macro textured implants include the Natrel implant, which was in widespread use for many years. Allergan produced this and have just recently issued a worldwide recall or ban on its use. So we as plastic surgeons are not able to use this implant anymore. It was a clever design. It was a good implant in terms of what it was able to deliver, but unfortunately it does have a macro textured surface, and the incidence of ALCL in that particular surface is hovering, depending on what you read, and I tend to follow the work of Anand Diva and his team, we're looking in the 1 in 3,600 sort of territory for a macro textured or grade 4 device. Some of the polyurethane devices, some of the Silimed type devices in terms of the macro textured surface are also in that category. The step down from that, we start to enter into texturing that's considered micro textured, and this is what we see from Mentor and from other providers as well, but this is the Mentor one that I've got in front of me. I'm not owned by any of these companies, by the way. I'm not sponsored or otherwise. But the micro textured Mentor implant is available on the market still. It's the same surface as what we use in the CPX4 tissue expander from Mentor. It's a good implant. We've been using it for many years. There's no particular concerns with that, but the ALCL risk profile of this is listed at 1 in 86,000. So it's a step down significantly from the grade 4 and grade 3 textured devices in terms of ALCL risk, sort of hovering from, as I said, 1 in 3,600 down to 1 in 86,000. Texturing also is present in the Motiva implant, and a lot of you are probably aware of Motiva implants now. We've been using them for a period of time now in Australia, and they have been used internationally as well. But these are a nano-textured implant. And so a nano-textured surface under the electron microscope does have a variation in the surface, which is not as deep or as creviced as a micro or a macro textured surface, but it still has a change compared to the smooth. So it is still a textured implant. We haven't seen any ALCL cases with Motiva that I'm aware of. Certainly in terms of the smooth implants, we haven't either. But there's a bit of debate, a bit of sort of talk around town of some cases in the United States, potentially of ALCL, in patients that have had multiple implants in the past and they've taken a smooth implant out. So maybe there's an association with smooth. It's more likely that they have had a textured device at some time in the past based on the research that's been done to show the causation, which is a bacteria getting into the crevices and stimulating a slow cell turnover that has essentially resulted in a genetic change with time that's triggered that problem. So yes, the question, are all textured implants bad? The answer is no. We've got a grading system looking at macro, micro, nano-textured surfaces and smooth, leading from 4 down to grade 1, which is a smooth. The Motiva is also categorized as a smooth, essentially in that grading system. And they carry a monumental decline from 1 in 3,600 down to 0, depending on the texturing involved. At present, we are still able in Australia to use the micro-textured, nano-textured and smooth implants. The macro-textured Allergan implants we have moved away from, and other brands as well. Now, the next question that I received was, what about the seemingly more reputable brands like Motiva, and what's the difference between micro-textured and macro-textured? Are they all more risky than the smooth? Which I sort of have spoken about, but just to sort of answer that one specifically, Motiva, nano-textured, Motiva, Mentor, micro-textured, and the macro-textured that was in common use in Australia was the Allergan Natrel implant. What's the difference? The difference is the size of the actual pores present on the implant proper. And as you, like on my ear, and I'm actually able to feel these things, but the Natrel implant, it feels quite sticky, as in like you would put it in someone and it almost feels like a Velcro. And that was the design. That's what they were made for. Your body was meant to incorporate into the surface so that it locked in. And you got this really good implant soft tissue interface so that you can create shape. The micro-textured implant from Mentor, same sort of thing in terms of what it was trying to achieve, but it just has a different texturing process. And as part of how they've defined this, they've now said that the pore size or the depth of the size of the little corrugations is a lot smaller than the macro, and so it's graded differently. The nano-textured, very small little depths within those little surface ruts, and then the smooth, obviously, there's none. Now, are they all more risky than the smooth? As I was saying before, we know high risk macro, lower risk with the micro. The nano-textured Motiva, we haven't got any other nano-textured on the market. We haven't seen any ALCL cases with Motiva yet. It is a relatively young implant on the market though. And then the smooth implant, we haven't seen any at all. So are they more risky? The micro and macro, definitely we've got data, longer term data to show what the rates of ALCL are with those devices. Motiva, youngish implant, but the science suggests that we're not seeing the cell interaction with the surface of that. So we've categorized them into the grade 1 band on par with a risk profile similar to the smooth. Okay. Now, any questions about any of that? Now, I'll move on, but by all means, I'm sure things will come up here and there about that. The next question I received, why did only Allergan recall their textured implants? What about other implant brands? So I'm not there in the background seeing why they made all of this decision. Separate to the data and the information that we do have about ALCL in relation to texturing and the link that has been shown by the various research groups around the world, it was deemed that within our literature that a lot of us found that the risk of ALCL was high enough with that implant that, just considering there's other options that we can use, we could use those and have a safer risk profile. There's no position currently, or no suggestion from the TGA, which is the Australian group, and the FDA, which is the American group, that anyone who has an Allergan implant should voluntarily have them taken out. If you are asymptomatic, there is no suggestion that you should actually have them taken out, because at the end of the day, ALCL is still a very rare problem, okay? So ALCL, low risk in terms of the implants, but higher risk in the Allergan group, which might explain why they recalled it. We also a lot of us were moving away from using the Allergan implants, which may have had an impact on their business. But yeah, it's mainly down to the research as to why I imagine they recalled their textured implants. What about other implant brands? We haven't had many other macro textured implants actually on the market that we as specialist plastic surgeons in Australia have been using. So in terms of the other heavily textured devices, I haven't heard much. Some of the other brands have had issues with supply, factory concerns and the like in the past, and whether they just haven't been so readily available compared to the more mainstream products such as Allergan. That might explain why others haven't bothered to recall. Allergan was a very big implant company in the world, and widespread use. So there are lots of people with Natrel or Allergan implants in place. The TGA's review, this was the next question. The TGA, so the Therapeutic Goods Administration of Australia, review of textured implants and implants in general means the authorities are admitting there is breast implant illness and implants can cause cancer. Why are some surgeons still questioning its existence? So I'm a member of the Australian Society of Plastic Surgeons and a member of the Australian Society of Aesthetic Plastic Surgeons. I'm also a member of the American Society of Plastic Surgeons. Now, we are not sticking our heads in the sand about breast implant illness, and we are not suggesting that it doesn't exist. At this point in time, patients that are presenting who have been appropriately investigated to exclude another reason as to why they have these symptoms. So we're needing to make sure that medically there's not another cause, such as anemia or other things, to explain certain degrees of fatigue or otherwise. If other problems have been worked out and it's likely that there's something going wrong with the implants, then I, as a member of that group, I'm happy to take them out. Speaking to the patient about what's involved, and obviously there's risks and benefits, and part of that is actually treating it properly and not putting our heads in the sand about it, and listening to the history, examining properly, walking the patient through what's involved so they can make an informed decision, and then actually doing the surgery and doing it properly, taking out the whole capsule, an en bloc resection, and having that capsule and implant and everything tested properly so that we can see if there's anything there, anything that's a potential cause. Is there something in the surface? Is there something bacteria-wise? Is there some other inflammatory cause? So I do quite a few explantations, and every single one I take the whole capsule and the implant out as an en bloc, and I send it all the way to be examined histologically. I've got a really good group of histopathologists who actually work with me on this, who are able to comment about elements that I'm looking for, and they know about ALCL and they know about other things in terms of what disease profiles we might be looking for. And so I ask that of them, and if there's any concerns, then at least we've investigated and we're pooling this information. All of my patients that I do an explant on, or any breast surgery on involving an implant, I send the information through to the Australian Breast Device Registry, and that is a central repository that's based in Monash University in Melbourne. And again, the patients that have their implants taken out, have the capsulectomies and all that sort of work done, that information is collated so that we can look for trends. And that's appropriate surgical management, that's appropriate medicine. If you stand there and say, this doesn't exist, that's improper and it's not good medicine. So when there's things that come up like this, and there's a bit of a cohort of people that say, hey, we think there could be something here, then yeah, we've got to do it right. We've got to make sure that we're looking at the data, we're collecting things properly, and we're then trying to provide solutions and answers for these patients. And that's the right way to do it. So why are some surgeons still questioning its existence? I don't know. I honestly don't know. There has been a bit of research into this field, and I think that's the thing. There's some that are saying, hey, there is something going on here. There was a paper out of Israel last year that said that, and they had a large number of patients involved. There's been a recent systematic review that was published in Plastic and Reconstructive Surgery, which is the main journal that we follow in plastic and reconstructive surgery. And they have suggested that they couldn't find any significant evidence to support the existence of this concern. They call it silicon implant illness over in America. But they supported the fact that further research needs to be done. So why are some still questioning its existence? I think it's natural. It's coming up. It's coming up as a point of discussion, and they're looking at the information from the past, which has deemed certain safety profiles. A lot of this has been investigated in the past. Keep in mind that back in the 80s and 90s, implants were actually taken off the market in America and Australia, silicon implants that is. There was a moratorium. They couldn't use them for 10 years. And it was all in relation to concerns from the general public about an increased possibility of developing similar symptoms and conditions to what have been ascribed these days to breast implant illness. So a lot of people have that memory of where things have been, but keep in mind that was with different generations of implants. And so to suggest that that's been investigated in the past and it's irrelevant now, we've got newer implants, we've got newer surfaces, we've got newer materials. There could be something in this, and that's why the breast device registry especially is useful, so that we can collect this data and pull it together and see if there are trends in the newer devices that can confirm or deny the existence of this problem. Okay, any questions from the group at all out there? No? I'll just keep going through the questions that popped up in my inbox in the lead up to this. So we'll move on to, does a remove and replace cost as much as a breast augmentation? Also, how does fat transfer compare in cost to implants? Now, keep in mind, I'm speaking from my side of things as a plastic surgeon in Brisbane, and my opinion on this is based on my own fee structure. Remove and replace, what's involved with that compared to a routine breast augmentation? So with a routine breast augmentation, we have native anatomy, no scar tissue. We've got the ability to plan and conceptualize and think about what we're going to come up against in terms of anatomical variations that might impact on the ability to do a procedure comfortably, efficiently, and in a reasonable time frame. Compare that to a remove and replace, where there's implants already in. Often we don't know what's actually in. And based on that, with what we understand with ALCL, macro-textured implants and the like, we need to try and get the capsule, we need to try and get as much of that stuff out as possible. So you're looking at an en-bloc resection, which can take a lot of time. It's actually quite a difficult procedure to do. And then once you've done that removal component, often in general, the surgical anatomy that is present in the residual pocket that's left behind, it's not the first operation, and the anatomical landmarks and some of the structures can actually be significantly affected by the removal procedure, such that you have to do a lot of internal work in terms of pocket modification, suturing down of certain structures to prevent lateralization, double bubble formation. There can be a lot of work actually involved with doing that, that's even before you then start to conceptualize what sort of implant and where it's going to sit. So you're essentially doing a removal, explantation, whole capsulectomy. You're looking at doing pocket modification to restore the original anatomy, and then you're looking at doing a primary augmentation on top of that. So it is a lot more involved, and I personally will put aside at least 2 hours to do a remove and replace, whereas with a primary breast augmentation, a lot of those can be done in 60 to 75 minutes. So it is difficult compared to a primary breast augment, and that is reflected in the price that a lot of people will charge. So in terms of my remove and replace cost versus a breast augmentation, yeah, it's a little bit dearer, okay? For me to put an exact figure on it is difficult because I actually don't know my exact figures right at this point in time, but I do know that it's probably about $1,500 to $2,000 more than a routine breast augment. Can you get any of this back on Medicare, health insurance, anything like that? Remove and replace item number changed last year. So it's only available to people who had a congenital problem in the past, tuberous breast deformity, for example, or some other agenesis concern, or if there was a significant contour abnormality present, or was it a breast cancer reconstruction. So there's all these limitations now on remove and replace when it comes to Medicare item number reform that occurred on the 1st of November last year. Now, how does fat transfer compare in cost to implants? So that's becoming more and more of a thing, us learning how to do fat grafting of the breast as a primary method to increase size, to do an augment using your own tissues. Fat grafting is good. We've been doing it for a long time in the reconstructive arena, contour irregularities, building up breasts. The things we've learned over time, we've learned how to process the fat to make it more reliable in terms of getting it to survive in the long run. And the figures that you read in the press these days sort of been 50 to 70% of any fat that you inject is likely to survive. We have to keep in mind when we do fat grafting, we're putting fat into areas where the fat has to be in contact with the adjacent vascularized tissue to survive. And so the techniques we've come up with in terms of radial clockwork type positioning of fat to try and structure circumferentially and then layer up ways that we can improve the viability of take or the likelihood of take. The process, the cost-wise, for most of us, I think a lot of people are probably charging as much as a primary breast augmentation for fat grafting, fat grafting versus implant augmentation. It does take a lot of time. The consumables, although we're not using an implant, are often liposuction cannulas and fat processing material, which is often disposable and quite costly. One of the systems that I routinely use has got a bag attachment for filtering the fat, which can cost anywhere between $250 and $800. And breast implants alone can cost in that vicinity, if not more, depending on what you use. So fat transfer is pretty comparable to the cost of implant-based surgery. And as I was saying, there's a risk of it not all taking. So if you are going to consider fat grafting, you potentially need to be prepared for a redo or a top-up of some form. And that's something that a plastic surgeon would normally consult and advise you of the risk of having to undergo. So you need to factor that into the costs. There's starting to be a few questions coming up on the screen. So I'll direct my attention to those for the moment. Anonymous question, do you do fat transfer after removal if it's a 250 implant? It depends on the skin envelope in terms of where we put the fat. So as I was saying before, I've got to inject fat into a plane where I've got good vascular tissue around to allow it to survive. The analogy is that I'm seeding the ground. I'm putting a seed into soil and it's got to grow. If you get a whole big chunk of seeds and just put them in a patch of soil, the seeds in the middle are not in communication with the soil. So there's no sort of nutrient there to keep it alive, and the seeds in the middle will die. So it's the same sort of thing. It depends on the thickness of the tissue in terms of how much space you've got to put to put the fat. If it's a 250 implant, that's usually a smaller person, but it can also be an implant that maybe was positioned just to give central projection. So it depends on the thickness of the tissue around, but certainly it's likely that it's able to be achieved. Do I do facial surgery? Yes, I do, depending on what it is. Obviously lots of skin cancer work and facelifts. Ray Go, I'm in practice with him here in Brisbane at Ballet Plastic Surgery. He does a lot of rhinoplasty work and revisionary rhinoplasty work, and so I send all of them to him, and he does a lot of chin and cheek implant work and revisionary work like that. So that sort of facial surgery I redirect towards Ray. But if you have a question about facelift surgery, neck lift surgery, then by all means send it along tonight. Now there's a question here from Rachel. How do you choose a type of implant and how long is the hospital stay for implants? So when I assess a patient that comes along for implants, one of the first questions is what sort of look are they chasing? Is it a natural look, or are they looking for something that is a little bit more obvious? And that's where with implant availability in terms of what we've got, we have a range of teardrop shaped and then we've got a range of round, okay? And so you've got to listen to what the patient's chasing. You can also think about, obviously part of it is the examination. You need to think about what sort of implant you need in terms of position of their natural tissues. You need to think about what size, like in terms of how high they are, how wide they are. If I were to use a round implant in someone who had a short breast base and they're looking for a natural look, then obviously you have a lot more volume above the axillary crease. So that can mean that that's not an ideal scenario, even though they prefer a round implant. In some patients, the dimensions are great and you can sort of look at them and say, you need just volume and a nice round implant is just going to do the job. So it really comes down to what sort of look the patient wants and what sort of anatomical scenario is in place. A lot of the time when I'm looking at the anatomy, it's an assessment of the chest wall in terms of width and height, as I was just mentioning. Then you have to factor in the breast envelope that you're looking at, the thickness of the tissues, the quality of the tissues. Massive weight loss tissues are important. Has a person breastfed, all of that sort of thing as well. And then we need to think about lengths and measurements of certain degrees of the envelope, the nipple position. Is it above the fold, at the fold, below the fold? Is it something where the distance from the fold up to the nipple is long enough or short enough so that an implant will actually stretch and fill it out and lift the nipple forward, versus is it a situation where there's no way a volume of implant is going to fill that out, so they need to then consider a lift, okay? So lots of decisions for implants. That's why when you look at the catalogues, there's so many options. You know, patients that come along, they sort of see me holding this up and it looks like gobbledygook, but there are small, medium, large projection. There's, you know, low, medium, and tall height. There's all different widths, and that's just in one brand. And then you sort of look at all the others in terms of what you can achieve, and then you've got to line it up with what sort of look the person wants. So there's actually a lot of decision making that goes into implant-based surgery. It's not just a case of make the hole and put something in and everyone will be happy, which is appropriate. We should be doing something that's planned and scheduled to achieve what the patient is looking for. How long is the hospital stay for implants? Most of my implant surgery is day case. And so recovery for a number of hours and you go home, and if there's any issues, back in touch, but obviously that's not common, and lots of follow-up to make sure that things are progressing appropriately. So another question, are you offering breast implant checks for patients if they're not yours? Yes. Lots of patients have had implants at different stages throughout their life. Lots of people, surgeons have moved, or they've forgotten even who their surgeon was, or they've had surgery overseas, or the surgeon's retired. So certainly any patient that has an implant, that's the sort of work that we as plastic surgeons do. And I personally am more than happy to see a patient that has an implant and there's a concern. So yes, if someone wanted to have their implants checked, I'm more than happy to see them. Okay. There's a question in relation to that facial surgery before. Do you do the S lift at all? So again, that's a nomenclature attached to a certain type of facelift. And there's multiple different styles for facelifts, and it's the sort of thing that it depends on where the tissues are sitting, both in terms of the deep plane tissues, the fat pads and the like, and whether they need to be adjusted. Over the top of that are other layers as well, and then we've got the skin to manage. So an S-lift, yes, if it's appropriate, but it does depend on where the condition lies in terms of what you actually need. Okay, and that's just a proper assessment to tie it all together. Okay, now there's a few other questions that I received earlier on again, so we'll go back to that. How big can you go with fat transfer? I've heard that you can only do so much fat in one operation. Does it cost twice as much to go back again to go bigger? So again, I was saying earlier that you can only inject the amount of fat that's going to sit within the tissue so that it can actually get a good blood supply. Okay, so you can only put in so much. If you put in too much, then you can run into issues with oil cyst formation, or a deposition of fat that doesn't get a blood supply, and then it can be variable in terms of whether it forms a hard lump or whether it gets resorbed, okay? Now, hard lumps can contribute to volume, but they can also be something that causes anxiety in the future in terms of what it is. Breast cancer is so common, and so that's one of those things where you've got to look at risk profile and managing that. How big can you go? As I said, it's dependent on that. It's also dependent on the donor site, and I've got patients that their fat is at a premium. They've got next to nothing. The common sites that we go to: abdomen, flanks, medial thigh, lateral thigh. But I've had patients that are so slim that I've taken it from behind the arm. I've taken it from even underneath here. So it really depends also on how much donor fat is available that we can actually borrow. I've heard that you can only do so much fat and why not. Again, it's limited by a judgment call on what you're trying to achieve and how much space you've got to put it into. And does it cost twice as much to go back in again to go bigger? That's a discussion that you need to have with your surgeon, okay? Because the price schedule for fat grafting needs to factor in that potentially you've got to go back in for a top-up. Because the variable that we don't control most of the time when it comes to any of this surgery is the cost of the operating theatre and the use of that time in there with all the staff. So there is a potential to have that cost twice. There's also, and that comes down to the relationship often that a surgeon has with the hospital. The hospitals that I work with have got very good terms with our fee structures for the work that's considered cosmetic. And it has to be like that because otherwise the work is done elsewhere or not at all. So we often have got good relationships, but you do need to factor in that cost element in terms of the use of the operating theatre, okay? Apologies. Can you choose where you have liposuction to get the fat from? Yes, you can, but it is an assessment on how much fat is likely to be recovered from that particular zone. So as I was saying to you before, abdomen, the lateral thigh, medial thigh, and the flank region around the back, they're the commonest donor sites that we actually get tissue from. You can actually get quite a lot of fat out of those particular zones. The slim people, you would know, if any of you have ever looked at massive weight loss and body lift type surgery, there are some fat pads that everyone just has, even the really slim people, and they tend to sit in the flank region especially, and in the medial thigh. So they're actually areas that are pretty common that we can take from. But yes, if you have a particular, the question that I always ask when it comes to a fat grafting scenario is, where is the fat that you don't like the most? Choose your area that you would like changed, and have that answer in your mind for when you turn up on the day of surgery. And that is an area where I'll ask them when they arrive. I say, right, what's the area that you want me to try and deflate? And we take it from that particular zone. What's the rate of fat absorption into the body? Can the fat disappear in the weeks following surgery? So as I was saying, 50 to 70% take is what we expect. It's really interesting if you look at the science of this, and this work has been done down in Melbourne, in the Bernie O'Brien Institute down there, and we saw this presented a while back by Wayne Morrison, who was a plastic surgeon down there. And if you look at under the microscope at samples of fat grafting, we quote 50 to 70% in terms of take and volumetric assessment, but the process is interesting. At a number of weeks post-placement, you actually go from surgical edema, swelling, fat, to the swelling and all of that depleting, and the actual fat depleting, and you reach a point where you've actually got about 20% take, and that's all for a period of time. And then we start to see the stem cell impact, and the stem cell impact actually sees the fat cells actually increase in size and increase in number, and that's where we see the volume recovery back up to about 50 to 70% at the 3-month mark. So any of my patients that I fat graft, whether it be for reconstruction or cosmetic, they hear me say, we're going to do a round of fat grafting, we get you back a week post-op just to take some of the little stitches out, and then I basically let them go, advising them of the process. And I say, expect volume depletion and then rebound. And I say to them, I'm going to make a judgment call at 12 weeks post-op to see whether it's enough or do we need to do more. Okay. On that note, I do want to make a comment about fat grafting because it's something that we're starting to do a lot more of when it comes to the cosmetic scenario. And the issue there is that implants can sometimes be the only solution that I have when it comes to what problem I'm facing. And it can be that I need an implant to provide some structural integrity to give shape. And in some patients, I can't actually get enough fat to create the shape. So that's something that when we are making a judgment call about fat transfer to the breast, I need to make a call on, am I looking at volume replacement or am I looking at shape creation? And is it a shape creation that I can give through combination fat grafting with a mastopexy or a breast reduction sort of scenario? Or is it a scenario where I'm just going to have to use an implant to achieve what we're trying to do? So that's something that a good discussion with your surgeon about what you're aiming to do, volume correction, shape. Are we entering into a mastopexy discussion with fat grafting? Keeping an open mind about implants. And as I was saying earlier, the biggest issue with implants, apart from the ALCL breast implant discussion that's happening at the moment, in my mind, is the fact that yes, it's a foreign body and there's a possibility that you're going to have something done to revise that in the future. So you need to be prepared for that. So yeah, fat transfer, there are limitations on what we can do with that, but that's evolving. You know, there's lots of research being done. We're all going to conferences locally and nationally and internationally to try and see what people are getting away with, what instruments, what new equipment to process the fat to increase our take rate so that we can have less procedures for people and achieve more. Okay, so things are evolving in that regard. There's some more questions coming along. There's a comment, amazing information around fat transfer. It is amazing, like quite honestly, fat transfer is probably the biggest change in plastic surgery in the last 5 years. I'm having this done along with new implants next year. Good. That's a scenario that is referred to by some as a hybrid breast augmentation. So again, where there's limitations of fat grafting in terms of creating shape, there's actually benefits from fat grafting occasionally when it comes to actually creating the shape we want. And so we can go into a volume enhancement with an implant, but if we're actually wanting more shape in the medial zone, for example, or to overcome some congenital concerns like tuberous breast where they've got tight folds, we can do fat grafting to different planes in the skin to actually try and create that shape or that shadow line to give you what you want. So that type of hybrid type breast augmentation where you're combining an implant with fat grafting can be a really useful thing. Now there's a question here, having implants put in as a 31-year-old, should I assume I will need replacement removal in my lifetime? I would counsel you that it's likely that you will, but it's for two reasons, one of two reasons. Number one, it is a product, okay? And the comment that I quite frequently make is, think about a paper clip. It's a really stable construct. It can hold all these things together. But if you sit there and pull it apart and start to wriggle, eventually it can snap. And the same with any of these implants. And they do lots and lots of testing on these things to try and see what sort of, you see the videos of people doing this and you see people doing all sorts of things to implants, but it's the constant movement. And that's what we found with, the little micro tears in the textured implants. And do you get little tiny movements, which at those little tiny pores can create just an area of fatigue, forming a micro tear, which with time can form a macro tear, which can then break down, causing a rupture. So it's often not a single traumatic event like a car crash that causes a rupture. It's those micro movements, the paperclip type analogy, that sees that the device can fail. So being 31, you've got years and years of that. Now, I've had people that have come along with capsular contracture of implants, or they've gone through menopause and seen a significant increase in breast volume and have said, hey, do you mind taking the breast implants out? And I've taken out 35-year-old implants, 40-year-old implants that essentially look like this, and they're smooth and they're intact and they're fine. So it's possible that you can get through life without a device fatiguing or failing. The companies these days do have warranty programs in place. They're pretty confident of their product. But again, these sorts of things you just need to be prepared for because they can happen. The second thing, apart from device failure, is just what your body's doing. And so here's a weight, here's a construct of tissue, and how long or how strong is that actually going to sit and sort of hold in place? And the advice I give to patients, if they're in their 20s, think about the next 20 years. You potentially might lose weight, put on weight, have kids, breastfeed. To the patient that's in their 30s to 40s, same sort of things. To the patient that's 40 and over, commenting about menopause, for 50 to 54 is a pretty average time for menopause. And there can be hormonal axis changes that actually decrease or change the thickness of the breast tissue. I do lots of breast reduction surgery. And if I do a breast reduction on an 18-year-old, I'm dealing with very different tissue compared to a 55-year-old. The postmenopausal breast is very soft and the tissues are more fatty than glandular. So there's changes in the actual physiology around the breast and the anatomy that with time can see that tissue change in its position in relation to the implant, or the implant not having the same impact on the skin envelope that it used to have. So with time, there can be a need to do a revision of the surgery that was done in the first place just to correct the appearance to match. And that can be a judgment at the time. If the implants, if you have an ultrasound mammogram, ultrasound or MRI that says, hey, the implants are totally intact, you've got a good capsule, they're a good position, but it's just that the breast tissue has come off the front a bit, we can just do a mastopexy and put it back on. So there's things like that. There are situations where the size of the implant for the skin envelope doesn't match anymore because of menopausal growth. Things like that where you might want to take the implants out or upgrade to a bigger implant or something, upsize I should say, not upgrade, but just increase the size of the volume of the implant and take out some of the sagging tissue that has got stretch marks or other concerns with it. So there can be things that mean that you need a revision with time, okay? Other comments coming through. Yep, so Siobhan, yep, as per what we were saying. I've got other questions here. Does it cost extra to get a lift when you get implants taken out? Yes, it does. So if we look at basis of cost in anything in life is what's the product you're getting in terms of physical form versus, and the other thing is just what's the labor involved in the process. And the labor involved in taking implants out versus taking implants out and then doing a lift, there's a lot of work, pardon me, in terms of that component in the mental preparation, the pre-operative sort of planning, and then the decision making on table. And this is the thing where taking implants out, yes, it can be difficult, but we always plan for an en-bloc resection these days in terms of taking it out with the capsule, usually through an inframammary incision if we're just taking the implant out. And that takes time. But then doing a lift on top of that, we don't know often what the implant was that was inside, where it was positioned in terms of its apex point, volume-wise, exactly what it was doing. And there can be problems where you take the implant out and your operative plan that you thought you had in terms of where you wanted to sit the nipple is going to be too high, too low, or not on the exact spot. So you do need to make some on-table decisions which take time. And then there's the whole process of, okay, this is the thickness of the tissue, this is what's safe, this is where I can lift things up to keep the nipple and everything alive, and the skin edges alive. So, doing a lift after taking implants out is a much more involved process. And so there is a cost involved with that. And that's variable, that's dependent on the surgeon that you're dealing with, where you live and what's and who's doing it, okay? But considering that, that's something where you should actually be getting the proper advice before you actually do have the surgery done to tell you what the costs are that you're looking at so you can weigh it all up. There shouldn't be any surprises there afterwards, okay? Now, does Medicare cover explants if you suspect you have breast implant illness? If so, do I need a doctor's referral or do I have to see a plastic surgeon? So, Medicare will cover removal of implants, explantation. The exact wording for explantation, so I haven't got it in front of me, But essentially, if there's any particular patient concern about implant pain, movement, capsular contracture, any of those things, which there often are in some form, then we can take them out. And there's a Medicare rebatable number attached to that, and the Private Health Insurance Act, if you have the appropriate level of cover, will mean that your procedure has got an element covered. Now, private health insurance is one of those things where what it actually does cover is dependent on your level of cover and the surgeon involved. It can go all the way to covering the majority of your surgery and anaesthetist, or it can be just the operating theatre usage and the hospital stay. And that's something that your surgeon should be able to tell you before you actually go through with things. Doctors' referrals give you rebates at the consultation stage, okay? It does help in terms of supporting the Medicare item number that's to be applied, especially if we're dealing with a health fund, in terms of having the evidence there to show that there was a medical doctor, a GP that referred you in, and it was deemed that you had this problem, and so be it. And so that's creating the chain of decision making to show that it was a problem and it needed to be addressed. So yes, if there is a concern with the implant, then Medicare usually should cover it, okay, in terms of contributing some monies towards your overall cost, okay? Now, are there any other questions that are coming through at all? I'm scheduled to talk for another 17 minutes or so. The things that have come up when it comes to breast implants, and I was talking earlier about ALCL. ALCL, I don't know, there's a lot of talk about this in the press and a bit of hype around implants causing people to die and all sorts of stuff like that. The big thing with ALCL is that it is incredibly rare. I have had to manage this. I've had a patient come through one of the hospitals, a public hospital that I work in, who had their implants placed elsewhere. I've had this on 2 occasions, and they're presented for medical attention. Outside of that, I've heard of one other case in Brisbane that I'm aware of. In general, in Australia, I think we're up into the 70s of number of patients, but someone might have more data than that. Internationally, we're looking at the 700 sort of region of actual cases. Now, in terms of deaths from ALCL, I think we're at 4 or 5 cases in Australia. And when you analyse those cases, which the surgeons have done and the medical boards and things have looked at, it's believed that it was a lack of, I guess, education and information availability of this concern. So people didn't know what they were dealing with. Surgeons and doctors didn't know what they were dealing with. They were taking fluid out. They were allowing the process to mature. And the problem with leaving anything like that to mature is that they become advanced. And so that's where they had problems with the resultant surgery and the requirement to have further treatments such as chemotherapy and radiation, which, as many of you would know, can have a significant impact on the body system and result in concerns where you can possibly have overwhelming infection and death. And that's what has happened. And that's where we're actually not against a lot of the media coverage of this particular concern, because it is giving people information about this problem. It is rare, but you all now know about it, and we do too, and the GPs and the like do as well. So the advice that I give my patients when it comes to implant-based surgery is you are at risk of having this when you have an implant of any type, although we don't have any documented cases currently for smooth or nanotextured implants. For the implants that we may need to use for people, for certain things, where I need shape, and we're looking at using a teardrop device that until recently has only really been available in a micro-textured or a macro-textured device, then the incidence rates that we're aware of in terms of 1 in 86,000, they're the things that we tell people so they can make an informed decision. Now, there are things that we can do that are called the 14-point plan. So if you're seeing a surgeon, just ask about the 14-point plan and they'll describe it to you. It's all about minimising the risk of bacterial contamination of an implant when it's actually placed at the time of surgery. because we know that ALCL is likely related to bacterial contamination of the surface of an implant. So there was a study done looking at the Allergan implant, which is the Natrol one that's been banned. And this was done by Bill Adams in the US, and he showed that it reduced the rate of ALCL with this group, with this type of implant, down to 1 in 42,000, which is quite different to the 1 in 3,600 that we've got documented. And that was all through the use of the 14-point plan with the use of betadine antiseptics, Keller funnels, which are devices that we use to put the implant through the skin without it touching the skin. Using no drains, using clean instruments to manipulate, changing gloves. There's all these things that have actually been ascribed to reducing that incidence. Now, the evidence to support all of that, otherwise, the individual things has been questioned, but it's something that plastic surgeons are doing to try and reduce that risk. Okay. So, yes, giving them that advice about what they're dealing with so they're aware of the incidents, but also telling patients at the time when they're considering implants that this is what can happen, and these are the things to look out for. And if you wake up in 8 years from surgery and you have a swollen breast, it's feeling tight, it's firm, that's a cause for concern, and you do need to actually get in touch with a medical practitioner, hopefully your plastic surgeon who placed the implant, and that deems review, assessment, possible further investigations in terms of ultrasound, fluid aspiration, testing for the appropriate markers for ALCL. And if they come back positive, removal of the capsule, the fluid, the implant, and then making a decision about leaving it or placing another implant, all deemed safe at this point in time. If we actually get it at that swollen point, we're not dealing with necessarily a life-threatening scenario. The evolution of ALCL in the body around an implant actually goes through a progressive precancerous type phase. It's a type of lymphoma, and lymphoma is a cancer of blood cells or inflammatory cells. And we see a trigger point where the number of inflammatory cells within the fluid increases in terms of its overall percentage of involvement of the fluid. And when we get to a turn point of about 60%, it's deemed a monoclonal expansion of cells, and that is then deemed a cancerous process. So there is a period of time there where it's a pre-cancerous environment, and that's where early investigation, early management can be enough to mean that in terms of your overall, or in terms of the overall impact and significance of this concern on you as a patient, it's quite low. So it's risky, and if it's treated properly, the impact is low. And that's where, yep, it's in the press, but that's a good thing. It's teaching people about the fact that it exists, and so that they can make proper decisions in the future. Okay. So there's a question that's come through here. Curious to know, I've textured implants which I believe are now banned in Australia, but my implants have never softened. They are rock hard. They don't cause pain. Is this something I should hurry and get checked, or is it not such a worry? Right, then there's a follow-on. They've been in 3 years. Maybe time I stop putting it off. So being in for 3 years, if you actually look at ALCL in terms of the cases that occurred worldwide, the range of presentations have been 3 to 14 years. The average point being 8 years. Firmness around an implant, if it's been like that from the word go, I would get this investigated regardless. You should probably go and see a plastic surgeon to discuss. But firmness is not necessarily a sign or a symptom of breast implant ALCL. It could be something that is capsular contracture. Capsular contracture actually does form within the first 12 months, but it can obviously worsen beyond that. The implants themselves, in terms of the pocket, the tightness of the pocket, the tightness of the muscle envelope, they can affect the feeling. Also the implant, in terms of what you had put in. And there's 3 different grades of silicone thickness, 1 being the softest, and then 3 being the firmest. And sometimes the implant can be quite a firm implant if they were trying to achieve a certain shape or to overcome some sort of element that was quite hard otherwise. So the rockness of it could be multifactorial. ALCL tends to present, as I said, with a swelling, but it can present with a mass. Okay, and I honestly feel any mass in the breast that's new, and this is where we encourage people to do monthly breast examinations in this country. Any mass that's new that's of a concern should be investigated. So general hardness, I would still have assessed to make sure there's nothing else going on, or nothing of significance. But in terms of the big things that we are looking for, it's a mass or it's fluid. Okay, fluid feels like it's a swelling and it's a tightness, and it's usually something that's building up over time. It's something that is coming up as a point of potential alarm for patients when they do have routine imaging done for breast cancer screening, and the ultrasound is saying that there's some fluid around an implant. It's quite common to have a little bit of fluid around an implant on ultrasound. 10, 20 mils of fluid within a pocket is something that we do see, okay? It's the attached symptoms of a sudden change, a significant change, and you feel it as a tightness and you see it as a fullness. They're the sorts of swellings that we've been seeing in this particular group, okay? So I'm coming to the end of my session here. If there's anything that's a burning question from the group, feel free to let me know. I will, if you want me to mention different types of implants. There was a question before about choosing implants and what to do. I'll just have a few minutes about what sort of things are available now. And as I said earlier, I'm not sponsored, owned, or anything by any of the companies. I do sit on a scientific advisory board for Mentor implants, and I have done speaking things for Motiva implants. I'm the Director of Plastic Surgery at the Royal Brisbane Hospital, and I am involved with what sort of devices we feel comfortable about using in the public sector as well. But of course that has to be a very robust process that's not open to corruption. So declaring my interest, that's where I lie with those things. The implants that I personally use these days are a combination of micro-textured implants, which are the Mentor implants. If I'm needing to create shape and someone's wanting a natural shape, it's a common implant for me to use in breast reconstruction or for postpartum rejuvenation in terms of fixing up an empty skin envelope. Useful in breast reconstruction after massive weight loss as well. We've got a newcomer to that arena, which is this device, and I've used this twice. It is very new. I, through the special access scheme, used the first one in this country. It's not completely TGA ratified yet, but it's the Motiva TrueFix, and so this is the Motiva anatomical. It is a nanotextured surface. The thing with nanotextured is that you just don't form much of a capsule around it, and so the benefit, or the reason why we were using texturing and other anatomically shaped implants, is because we're trying to get a soft tissue implant interface that means that it doesn't rotate. And a lot of you would know that if you have a teardrop shaped implant and it moves, it can change the shape of your breast. So you can see that this device, the micro-textured, it's missing something which this one has, which are these little tabs at the back. And so that smoothness of that surface, we're needing to use these things, which are called suture tabs, to actually lock this implant into place onto the chest wall. And so in the cases that I've used, and Charles Brankvist over in Sweden, he's actually done a series, which you can see online, where he's published 400 cases and techniques on how to secure this in place without ill effect. And that's what we're doing. So that's a new device, the anatomical Motiva TrueFix nano-textured surface. It's a grade 2 gel in terms of the thickness of gels. So we look at 1, 2, 3, 1 being the softest. A number of you would be aware of the Motiva Ergonomics implant, which is their sort of hybrid type implant. It's been marketed as a gel that moves within the implant. So it rolls, forming a natural flat shape when you're lying down, and then when you stand up, the gel forms an apex point, which is 45% of the way up from the base, 55% of the way down, which is pretty similar to what we see with a teardrop shaped implant. It's a Co1 gel as an equivalent, okay? I don't know if they label it as such, but the anatomical one is a firmer gel to try and give us shape. So this is an option that if you've got enough lead time and it's something which you think might suit your scenario, or your surgeon might think your scenario would require, it is available through a special access scheme, which is a special thing through the federal government, okay? The other implant that we've got, which is new, This is called the Memory Gel Extra from Mentor. It is a smooth surface implant. If we look at other implants, and I've got my fruit bowl of implants, which my trainees think is hilarious. But if we look at a traditional smooth implant, let's see if that lines up. You can see how the fill of that, the shell is not actually as full as this one here. So you can see that the Co1 traditional smooth implant from Mentor is sort of underfilled. The new Memory Gel Extra has got a fuller, it's got a greater content of silicone within the actual implant, so it doesn't have that emptiness. They've designed it in a way where compressibility, when you press on it, it's got a bit of firmness to it, but from the sides, it's actually really soft. And it's something which you actually can feel the difference. When I went to the States in March to the scientific board for Mentor, and we had cadaver labs where we could actually feel the difference between this and this within patients, and it was a significant difference. So that's been TGA approved, the Memory Gel Extra implant, and and it's one of the latest things. It's my American colleagues, they all love smooth implants over there. They don't understand why we would use textured, but yeah, they like the smooth ones, and a lot of them are finding that that's a good implant. I myself, this is pretty full. It's one of those things where I'd probably say to the patient who wanted the upper fullness of an upper pole, that might be a go. It certainly would be something where if someone said, I want a nice natural slope, it probably wouldn't so much. But again, I don't have a lot of experience with that one yet because it is so new. The other implants, there is a different Motiva, which is similar to the Memory Gel Extra in terms of the fill. So it's called a Progressive Gel Plus, and it's just a firmer, fuller volume of implant, but still with the nano textured surface. So yes, at this point in time with my fruit bowl, what we're using, smooth, traditional, smooth Memory Gel Extra from Mentor, nano textured Motiva Ergonomics, and the Progressive Gel Plus, the new True Fix anatomical shape when needed, and and that's pretty much it. Okay. There's some other questions there. Deb Bailey said, thank you. What's his name again, the guy that did 400 cases? Trish, it's Charles Randquist. So he does a lot of teaching. He used to do a lot of teaching through Allergan, and now he's doing quite a bit with Motiva. And yeah, I think he's done a white paper on his use of 400 Motiva True Fix anatomical implants, and just techniques and issues that might arise. He does a lot of breast implants overseas, that fella, and so we sort of listen to his teaching and direction at times. There's one final question which I'll wrap up on, and what we've got, it said, I had silicone implants that leaked into my lymph nodes. I've had the implants removed. So that can happen, okay? So the thing with silicone, so silicone is present in our diet. Anything we eat that's grown in soil, it's present in soil. It's a natural element. So our body is used to handling it. But certainly these volumes of silicone, if there's a rupture or otherwise, anything that's in us, our body will pick up within its monitoring system, which is all the lymphatics, okay? And the lymphatics are little channels that run adjacent to all of our blood vessels. They sit through all of our tissues, and they're the police. And they basically roam everywhere, but whatever they find, they take back to the station, and that's what your lymph nodes are, okay? So little micro deposits of silicone within the tissues can be picked up by macrophages, which are the surveillance, the police cells, and they take them back to the station. And the thing with silicone is that it just can't be broken down by the body. It's used to handling it, but these are larger volumes. And so the lymph nodes can accumulate that silicone. Now, what we do see, bizarrely, is if you do take that silicone load out, sometimes you can see the lymph nodes actually shrink down a little bit or not be as palpable. But lymph nodes, if you have a feel at the top of your groin, from running around in the backyard as a kid, you will have lymph nodes there that have stayed large, okay? And that's normal, okay? So, yes, you having it go into your lymph nodes, Is it a safety concern? Look, if it's causing pain, sometimes we actually address the lymph nodes if they're that large that they're pressing on things or irritating nerves. I've seen or heard of, I know of one patient that had such a rupture of such a large implant and such a silicon load that actually got further beyond the lymph nodes up into the channels. And it was more a question of what do we do about it based on an MRI study, and that sort of thing. She was asymptomatic, so, and that sort of surgery would be so involved. So it was a case of, well, let's just see, there's nothing we can really do about it. But again, risk benefit, was it harmful? No. So why put it through something that was severely harmful? So yeah, for your comment there about into the lymph nodes, is it harmful to you? Not necessarily. It's an element that our body's used to seeing. The nodes can just hold on to it and stay enlarged. Sometimes those nodes can shrink down once you've had the implants taken out. Would we go in and do anything about it? If they're causing you pain, discomfort, or there's something that causes alarm every time you have some sort of imaging study done, there's breast cancer surveillance. But if we're going to do anything about it, it's a risk-benefit thing. If you go in and try to take out a lymph node, are you going to disrupt other channels that might be draining the lymphatics to the arm? So the risk of lymphedema is there, and that's a pro-con thing. So there's a question there for Trish about facial surgery stuff. And yeah, look, I agree with you, Trish. That'd be great to have that. There's some really good facial plastic surgeon types around. Yeah, some based in Brisbane here, but others around the country. So I'm sure Trish can organise that. Okay, well, I'm going to wrap up. I thank you all for your time and attention. I hope that's answered whatever questions you may have had. I am based in Brisbane at Valley Plastic Surgery. I'm in the public sector at the Royal Brisbane Hospital as well. If there are questions that you have that come from this or you wish to catch up, by all means get in touch. We do have an email address, info@valleyplasticsurgery.com.au. We do have a website, of course, and there's Facebook, Instagram accounts and all sorts of stuff attached to me, Matthew Peters, but also to the practice, Valley Plastic Surgery. I'm one of 4 surgeons here in the rooms here, and we have a dermatologist as well, and we all do little different things. So certainly if there's another question about another element of plastic surgery that you would like to discuss with us, then by all means get in touch. Thank you to Trish for facilitating this, and I hope you all have a good night. See ya.